Good afternoon. We're going to get started. My name is Nicolas. I'm the director of the Geriatric Research and Education Center and the Barshop Institute. And my interest is in issues related to diabetes and aging. So today I'm going to talk about different aspects related to diabetes in the older population. So today I'm going to give just a summary about the epidemiology of diabetes in the elderly and why is it important. Also some basic concepts about the pathophysiology of diabetes, why does it happen in older people, and then we'll just go over some basic recommendations, more clinically oriented recommendations on how to manage diabetes in the elderly population, since this is a somewhat controversial area with a lot of unanswered questions. So this figure shows essentially the number of people with diabetes in the world, both type 1 and type 2, and over time, and it's essentially what you can see, it has been increasing slowly, and in 10 years, between 2000 and 2010, there was a very significant increase of about 80%. So just in 10 years, imagine the amount of diabetes in the world increased by 80%. So that's pretty very concerning. That figure shows also how diabetes changes, the prevalence of diabetes changes with aging. So if you ask yourself why diabetes has been increasing so much, there are essentially two main reasons. One is that, and when we talk about diabetes increasing in the world, it's primarily caused by increases in type 2 diabetes. So for many of you who are not that familiar with the terminology, there's, broadly speaking, two types of diabetes, type 1 and type 2. Type 1 diabetes used to be called juvenile onset, and essentially this is a process in which the immune system attacks and destroys the beta cells which make insulin in the body. And it happens more frequently in children and adolescents, although it can happen also even at older age. And type 2 diabetes used to be called adult onset, but that term was removed because it can happen at any age. And that type 2 diabetes is the typical diabetes we think of in overweight people. And that is caused, as I'm going to discuss, not because the beta cells are destroyed, the beta cells that make the insulin, but rather because the insulin that is made by the beta cells does not work properly in our whole body. So this astronomical increase in the case of diabetes in the world is primarily driven by type 2 diabetes. And so why is it increasing so much? There are two main reasons. One is obviously obesity. So as people around the world are eating more calories and doing less physical exercise, people are gaining weight, and obesity itself is a major risk factor for developing type 2 diabetes. The other reason, independently of obesity, is that with better healthcare around the world, people are living longer. So aging, per se, is also an important risk factor for developing type 2 diabetes. So the combination of more people being overweight, people living longer, and certainly combined, because a lot of older people are overweight, is really what it's driving this. Now, how do we know that aging is associated with an increase in type 2 diabetes? So this is a set of data that indicates that. So diabetes can be diagnosed in different ways, but one way is with a glucose tolerance test, which is a test in which a drink, a standard amount of sugar in a drink is given at a fasting state, and blood glucose levels are measured 2 hours later, and depending on the blood glucose level at 2 hours, the person can be classified as having normal glucose tolerance, that is, if the glucose level at 2 hours is up to 139. If it's between 140 and 199, we call them hyperglucose tolerant or glucose intolerant or pre-diabetic. Those terms are the same. And they're called pre-diabetic because a very significant portion of those subjects over 5 years or in the future will become diabetic. And then if the glucose at 2 hours is 200 or more, they are, that is diabetes. So based on that category, those categories, you can see that the cases of people with type 2 diabetes, that's the bottom in green, increase with age. Then for every person with diagnosed diabetes, type 2 diabetes, there's another person that also we can predict that there's another person with type 2 diabetes, but it's not diagnosed, meaning their doctor hasn't diagnosed it and they don't know about it. And then the largest portion are the pre-diabetics. So as I mentioned, based on that glucose tolerance test, these are people that don't have diabetes, but they might get there. And all those categories increase very significantly with age. So if a person is 65 years or higher, has a 50% chance of being diabetic or pre-diabetic. Or other way to put it, 1 in every 2 people that are 65 or higher are diabetic or pre-diabetes. So obviously we're all very concerned about this. So why does diabetes increase with age? So to illustrate this, I'm just going to give you a few basic concepts on the physiology of diabetes. In normal circumstances, when we eat a meal, obviously the nutrients get absorbed into the gastrointestinal tract. You see the stomach there, and then the beginning of the intestine. And as those nutrients get absorbed and glucose levels start to rise, the body does things so the glucose doesn't rise too much, right? So why do we have glucose in our body? Well, because all our cells need glucose as a substrate, right? But levels of glucose, if they are too high, the sugar is toxic to many of our cells in our body. So that sugar will get into cells such as the retina, the blood vessels in the retina, the nerve endings in the retina, or the cells in the kidney, or our nerves in our feet, and it's very toxic. So that's why diabetes is the main cause of blindness, because of retinopathy, main cause of kidney failure, main cause of amputations. So the body knows this and does things so glucose doesn't get too high, particularly after a meal. So what does it do to prevent that? It does many things, but probably the most important one is release insulin. Insulin is this a hormone made in the pancreas, which is here. This one here, sitting behind the stomach, and when it can detect when sugar levels start to rise, and it will release insulin. And insulin will go to many tissues, such as the liver, the muscle, and the adipose tissue over there. And insulin what it'll do, for example, in the muscle, it'll make the muscle take up more sugar. So the muscle is always taking some certain amount of sugar, obviously to oxidize it as a substrate, as a nutrient, and insulin accelerates that, makes the muscle take up a lot of the sugar. And so that way the sugar is not in the body anymore, it's in the muscle where it can be used. In insulin, what it does in the liver, it's a little different. Our livers are constantly making sugar. It's taking up different nutrients and making glucose constantly. And we didn't have any insulin, for example, like the type 1 diabetic, the liver goes crazy and makes enormous amount of glucose. So what the insulin in normal circumstances puts the brake on the liver. Tell it, don't make so much glucose. So that's another important goal or function of insulin, to maintain glucose in the normal level. One is to make the muscles take up the sugar from the blood, and the second is it puts the brakes on the liver so it doesn't make too much sugar. So that's how insulin works. Now, one of the very early things that happens in the pathophysiology of type 2 diabetes even before a person becomes diabetic, for example, in a pre-diabetic, is this. So let's assume a person who is very active and lean during teenage years. They're making their beta cells, their pancreas is able to make normal amounts of insulin, and everything works fine. But that person, when they after college, they start working, and they aren't so active anymore. So they start gaining weight. So gaining weight and the lack of activity causes what we call insulin resistance. So that muscle and that liver and the adipose tissue don't respond to insulin anymore properly because of the obesity and the lack of exercise. However, the beta cells are pretty smart, and what they'll do, they'll say, okay, this person is becoming insulin resistant, and the insulin I'm making is not working well. But I'm not going to allow this person to become diabetic. So the beta cells will start kicking more insulin. So they can increase it 2 times, even 10 times more of insulin to overcome that insulin resistance. So that's what we call relative insulin deficiency. Type 1 diabetic, where the beta cells are completely destroyed, we call absolute insulin deficiency. But in this case, in type 2 diabetics, their beta cells are making insulin. It's just that it's not enough. So it's called relative insulin resistance. Now, in the majority of people, about 80% of people who are insulin resistant, for example, of obese people that are sedentary, those beta cells can keep overworking for the rest of that person's life. But in about 20%, for reasons we don't know, probably genetic, those beta cells get tired over time. So when a person is insulin resistant, and let's say their beta cells were able to maintain that, prevent that person to become diabetic, but in 20% of people, those beta cells eventually give up. So that's when they become defective, and that is when a person becomes diabetic. When they've been insulin resistant for a while, their beta cells probably overwork for a while, but eventually they got tired. And again, that's only about, well, it is a significant amount, 20% more or less of the people that are insulin resistant. And there are ways to try to prevent or slow down that risk of the beta cells getting tired. One is through exercise, obviously losing weight, and certain medications might help that. So a key question that has been in the aging field, as I mentioned, with aging, there's a big increase in diabetes, right? So, as I said, to become diabetic, there are 2 problems need to occur. One is the person needs to become insulin resistant, and the other is their beta cells will stop working. So a big debate in aging has been, what is the main problem as we age? Is it that our tissues become insulin resistant, or that our beta cells give up, or is it both? So I'm going to talk a little bit about that. This is a test for insulin for beta cell function that we did, our research we did in 3 groups of people: young people, that's less than 25 years; older people they were over 65. The mean age was about 75, and based on the glucose tolerance test, they had completely normal glucose tolerance, meaning that the 2-hour test with the glucose tolerance test was normal, less than 140. And there were also some people that were older, and they were glucose intolerant, meaning they were not diabetic yet, but the glucose tolerance test was between 200 and 140. And we wanted to see whether aging itself would be associated with problems in beta cell function. And the key thing is that none of those groups were obese because we did not want to have that confounding effect of the obesity. We wanted just to see the effect of aging. And their mean BMI in the 3 groups was about 23 to 24. They were all healthy. We're not talking about older people with disabilities or illnesses. And they all had the same levels of physical activity. These were not athletes. We did not want to study athletes. So let's look at what happens in the beta cell. So to your left, you have the glucose levels during an insulin tolerance test. And to your right, you have these are the blood levels, and those are the glucose levels and the insulin levels during a glucose tolerance test. We give them a load of glucose, 75 grams, and then every 15 minutes we measure glucose and insulin. We put a catheter, obviously, because we're not sticking them every 15 minutes. So let's see what happens in normal circumstances in the young people who are in white. So you can see the glucose obviously starts to rise with the load of sugar. And then look at those beta cells to your right in white. They detect that the glucose level is increasing, and boom, they send a big bust of insulin. It goes up very fast, and then you can see that around 45 to 60 minutes, glucose levels start to decline, right? Because that insulin is working properly in the tissues, and because glucose levels start to decline, the beta cells, the insulin says, okay, everything's fine, I kicked out insulin, it's working well, I'm going to decrease it now, and it goes down. That's a nice normal response. Let's look at the older people who are not diabetic yet. So glucose levels start to go up, and you can see that in general, glucose levels are a little higher than, that's in pink, a little higher than the young people. They're still, in the older people in pink, they're not in the category of being pre-diabetic or diabetic, but certainly the levels are a little higher than in young people. And then let's see the beta cell response over there to your right. In pink, as you can see, the amount of insulin that they're making is not the same as the young people, and certainly it's sluggish. And now let's look finally at the older group who are pre-diabetic or glucose intolerant in green. Glucose levels start to rise, and look at the response of insulin. It's very sluggish, it's very slow, and therefore that's why the glucose remains high, and eventually the amount of insulin that is secreted at the end is pretty high, but it's too late. It should have, to function properly, that secretion of insulin in the older, with subjects with impaired glucose tolerance should have been early. Because it happened too late, the person had overall higher glucose levels. So as you can see, aging itself, focusing both in the normal and the glucose tolerant and the glucose intolerant, the amount of insulin that is secreted, it's not the same. So definitely there is as we age, our beta cells, for some reason, they cannot secrete sufficient amount of insulin. And we don't know why. Some people think that the beta cells are are derived from epithelial cells, meaning that they're constantly dividing, just like our skin or other epithelia we have. There's some evidence that the capacity to replicate slows down with age, but it's still very important. Now, but the other question that has been asked for quite a while, and we've been looking at that, is whether, as we age, our muscles are able to respond properly to insulin. Meaning, as do our tissues, such as the muscle, does it become insulin resistant as we age, independent of obesity or other factors? So, in general, most studies have found that as we age, yes, our muscles become insulin resistant. What is not so clear is that an effect of aging itself, or an effect of things that are around aging. For example, sarcopenia. Sarcopenia means muscle wasting. So is it because our muscle, the size of our muscles when we age declines almost invariably, so there's less muscle tissue to take up the glucose. So that contributes. The other is visceral adiposity. As we age, we tend to gain fat in the abdominal cavity, and the fat from the abdominal cavity, the visceral adiposity, produces substances such as what we call cytokines, which are inflammatory substances, that go to the muscles and cause insulin resistance. The other is low physical activity. So as we age, typically our physical activity declines, and being less physically active can also contribute to our muscles being more resistant to insulin. And so the question is, what happens if you control for other things, or the muscle tissue itself, if the other things are removed? For example, if you take people who are not sarcopenic, have normal physical activity, and don't have visceral adiposity, do they still have decreased insulin sensitivity? And that's what we've been looking at. So this is a study we did a long time ago. This is a test of peripheral insulin sensitivity with an insulin clamp, because we do them almost daily in the 7th floor. And it's a test, and we put our subjects in a bed, and we do a constant infusion of insulin and glucose to measure insulin sensitivity, and it's very precise test. The higher it is means that the person is more insulin sensitive, so that's better. And we had 2 groups, young and older people, 2 different age groups, and as you can see, insulin sensitivity was reduced in the older group in yellow. So why do our tissues become insulin resistant as we age? So it is not clear, but the main hypothesis, it has to do with what is called mitochondrial dysfunction. So what are mitochondria? I'm going to take you back to your classes, biology classes. You know, our cells have different organelles, and one of those organelles are called mitochondria, which are the kind of football-shaped organelles, although in reality they are interconnected, but in general they have that shape, and they're very important because they take up all our nutrients and they make energy in the form of ATP, right? So if you imagine, how does the food is converted to energy so we can walk and sleep and walk and eat and have and just be alive? Well, it's thanks to the mitochondria that they take up all the nutrients, lipids, sugars, etc., and they convert it into energy in the form of chemical energy, of molecule called ATP. So, and it's more and more studies suggest that the amount of particular studies from rats and mice, the amount and the function of those mitochondria decreases with aging. So I'm going to skip that one. So what happens with mitochondrial dysfunction with aging? One thing that can happen is, if as I mentioned, the glucose, all the different nutrients, such as fats, are normally taken out by the mitochondria to convert it into energy. But if the number of mitochondria is lower, then this mitochondria, which take up, for example, fats, and they burn them, then they start to accumulate, right? The fat will accumulate because that mitochondria is not able to take up the fat and burn it. So this is a study that was done at Yale University to measure the amount of fat in the muscle of older people. So in addition to fat being on the subcutaneous tissue, fat can also accumulate in our other tissues, and it can accumulate in the muscle, between the muscle fibers, and inside the muscle fibers, or in the liver, inside the hepatocytes. And that fat accumulated if it accumulates in these tissues, is very toxic. So this is a test that is essentially, it's done like an MRI, but instead of the software generating images, it generates spectra like this one. And from that, the software can tell us the amount of fat in our cells. Hello? Hello there. So for example, these feet, it measures the amount of fat, and from that we can tell how much fat there is. So in that study, older people that were 70 versus 27, again, these are lean people, have almost 80% more of fat. So the hypothesis is that as we age, for some reason, our mitochondria, the number of and function of the mitochondria goes down, and therefore there's less capacity to take up fat and burn it, and then it starts accumulating in our body.
So is that why people, middle-aged people, start getting the fat around the stomach and?
That is one of the reasons that, in general, the capacity of our body to burn nutrients such as fats and carbohydrates decreases. So that energy from the fat and carbohydrates accumulates. Not only in the visceral area, but throughout our body, the liver, the pancreas, and certainly in the muscle. So we did a test to see whether the function of the mitochondria is affected with aging. So how can we get the mitochondria? So we need to do muscle biopsies, and we do them all the time in the second floor. We do them here in the quadriceps, which is this muscle here. And obviously we do it with lidocaine anesthetic, and then we do a small incision, take that needle, and then we take a small piece, about 300 milligrams of muscle. And then from the muscle, we grind it, and with a centrifuge, we isolate the mitochondria, and then we put it in a plate reader with a reagent that lights up if they're, depending on the amount of ATP, which is the energy produced by the mitochondria, it'll light up, and the machine can tell us how much ATP is being produced, and those are the data. So we need to feed the mitochondria different substrates like pyruvate and malate. Going back to taking you back up to the Krebs cycle, mitochondria needs, these are the substrates that it'll use to make energy. And as you can see, regardless of the substrate we give those mitochondria in the plate, the amount of ATP that is made by younger people is about twice than older people. So for some reason, the amount and the function of those mitochondria is going down as we age. And so that is a measure of mitochondrial function. So of course, we as doctors, we want to improve that. So one way that we try to do that is with exercise. So we enrolled subjects from both groups, the older and young groups, and we had them do exercise for 4 months. It was a supervised program, and in the beginning they exercised. They were sedentary. Again, we don't want to do athletes because then it's skewed. They started exercising 2 or 3 times a week. The beginning it was only 20 minutes because we don't want to hurt them. You start too fast and they'll get injuries. And we increased it progressively. By the end, they were exercising 45 minutes at a high intensity. We went from very low. At the end, they were exercising 4 or 5 days a week at a high intensity for 45 minutes. So that is the protocol that we use, increase it progressively. So this is a result. This is the data just from the older people, from the mitochondrial test. Again, the higher it is the better, meaning those mitochondria are how much energy they can produce. And these are the different substrates. So let's just focus, for example, on the last one to your right. As you can see, this is all the older group. So in white is how much energy those mitochondria were making before the exercise, and in pink is how much they were making at the end. So essentially, it was doubled by the exercise program, and by the end, they had reached the same amount as the young group at baseline. A young group, I'm not going to show it, but the young group also increased even more. So it was skip to this. I want to give you more of the clinical part. So, as you saw, for some reason with aging, our body undergoes several changes. It becomes insulin resistant. It probably has to do, we don't know, but different factors. One is that the ability of our mitochondria to produce energy decreases, and that has consequences such as it impacts our metabolism, but also if those mitochondria are not taking up substrates sufficiently and burning them, they will accumulate in the form of fat, right? So what is really interesting is that exercise basically can rejuvenate the mitochondria. Some data that I have there, but I'm not going to show it in the interest of time, is that we did a whole bunch of genetic studies and detailed studies of the whole structure of the mitochondria, and it's amazing how aging, how significant the changes in the mitochondria are with aging, but also how exercise is able to revert the whole mitochondria structure and function back to a young person from a functional and structural perspective. And so this is fascinating to us, and we're trying to find out what it is. If we can find out what is the signal at the molecular level, how exercise is working, we might be able to design a drug that works in that manner. So now I'm going to jump to a more practical issue with diabetes. So why do we treat diabetes in most cases? In general, we treat it because very high glucose levels chronically can have, as I mentioned, it's toxic and can have significant effects in the eyes, kidneys, and legs. So that's why we treat our patients with diabetes, so they don't suffer those long-term consequences. Also, if glucose goes very high, the patient can become dehydrated and end up in the hospital with dehydration. And I'm talking glucose levels of 4 or 800. So there are acute complications of hyperglycemia, right? Such as ended up in the hospital dehydrated. So that's why the main reasons we treat diabetes, not just because we don't want our patients to have high glucose. There are well-validated reasons. However, it has been debated whether older people should be treated and whether they should be treated in the same way as younger people. And one of the reasons for this questioning is that not every person develops diabetic complications. Not every diabetic will develop the chronic complications. So, for example, let's say if we take 100 diabetics, 100 diabetics, and we don't treat them at all for 30 years, how many of them do you think that will develop kidney problems and the blindness? All of them? A few? Or would you just give me a guess? 20%? Yeah, so in general, the data, it's anywhere between 20 to 40% of those being, so it's a substantial amount, right? But there's also a substantial amount that they won't get it. So now, how long will it take for them to develop those complications? Yeah, so of course it varies in each patient, but in general, closer to 10 years. So that brings the question, if a person, let's say you have an older person who you've been following for many years, and you know they're not diabetic, but then you see them and they say, oh, now you become diabetic, we need to treat you. If that person is 75, would you treat them? Knowing that it might take about 10 years for the complication. Or if they're 65, how about if they're 90? Would you treat them? So those are things that one needs to think about, because treating a person involves cost, risks to that person, a lot of many issues that have to be considered. Now, one of the things in general, yeah.
Wouldn't that those would be ethical?
Yeah, absolutely. Yeah, so we'll talk about that. So in general, older people with diabetes compared to older people without diabetes, they do tend to have some higher incidence of problems such as premature death, disability, high blood pressure, cardiovascular disease. They also tend to have more polypharmacy, meaning they need a lot of medications, depression, cognitive problems, urinary problems, falls, pain. So there are some reasons that might make you be inclined towards treating a person. Now, this is so we talked about the age, right? So this is and how many years does a person has to live in the future, right? You cannot predict it as a healthcare provider. So when you try to make those decisions, tell, well, you're going to die in 1 year. Of course, if they have advanced cancer, but if not, you can't say 1 year or 20 years. So this is a study that was done here by Dr. Espinosa and Hasuda here. And what they did was they estimated the longevity of a person based on their functional status and their frailty status. So at the beginning of the study, these subjects were about 75. They were, in general, they were healthy. I mean, they might have had certain chronic conditions, but these were not patients with advanced cancer or something like that. And what they did in the beginning, they did a frailty assessment. There's scores, the different ways to score it, and they with the scoring, they categorized people either as not frail, it's in blue, as pre-frail, which is in red, and frail in green. So this is at the beginning.
How do they define frailty?
So there are different ways to do it. There are different scores, but one of the one that they use, the criteria, has things such as how fast can a person walk, the strength with a grip, do they have other comorbid conditions. So there's specific criteria. So let's see how many more years does a person who's about 75 has to live, depending on. So if a person is frail, and someone has a calculator, I always forget what is 5,000 days in terms of years. It's like 14 or something. So if a person is frail, as you can see, over time, the risk of dying, the higher means that all of them are alive in that category, and obviously people have started to die here. So by 5,000 days, which is how many?
13.7.
Yeah, so almost 14 years, almost all of them are dead at the end, right? If you're frail. If you're pre-frail, you can see that the rate of people are dying is slowed down. But then if you're not frail, you can see that it's slower. So even here at 4,000 days, which is probably more than 10 years, more like 10 or 12 years, there's a very significant proportion of people that are still alive, right? So we're talking about people that are, how many of you know people that are 75 or 80, and they're relatively healthy and non-frail? I'd say a lot. I mean, sure, there are a lot of people, especially if you're working in a hospital, but if you go to adult living facilities or other places, there's a lot, currently, there are a lot of older people that are pretty robust. So that's one thing to consider. More than the actual number of age, when you're trying to determine whether to treat or not, it's really how functional that person is. Here, if a person is fairly dysfunctional, they have 10 to 15 years more years to live. So they have the potential to developing diabetic complications during time period. So when you try to, if you're going to, so those are some recommendations from American Diabetes Association, the American Geriatric Society, joint recommendations. If you're going to decide, when trying to decide whether to treat an older person for diabetes, there are many things to consider. Not only whether to treat or not, but how tight control, right? Are you going to take a person who's 100 years and have their hemoglobin A1C at 6.5? And hemoglobin A1C is this measure of hemoglobin from the blood that gets glycosylated. And it's the typical test we do if we want to get an idea of how good or how bad the person is in terms of glucose control. So the normal is about less than 5.5. 5.5 to 6.5 is kind of borderline. And then over 6.5 is mostly diabetics. And And so the recommendation for diabetes, for how tied to control, typically is about lower than 6.5 or lower than 7, depending on which recommendations you follow. So would you follow the same recommendations in a person who's 100 years old? So those things are to consider. So in general, try to not think so much about the age, but how functional they are. That meaning, what is the life expectancy, and probably their functional status at home and work in general. So that's what I mentioned. Cognitive function, that's important because certainly how easy or difficult it's going to be to whether to control a person with advanced dementia. And you're going to put in a very complex regimen of insulin and sugar and things that they would have to do to maintain a very tight glucose control in someone who functionally is not doing well. That's probably not appropriate. You're just going to increase their risk for that person. And then this one is called clinical heterogeneity, or how prone is that person to complications. Now, so this has to do with what I mentioned before, whether every person with diabetes will develop complications or not. And you can kind of get an idea. For example, if you see someone who's had diabetes for 30 years and they never took care of them, but you see them and they don't have any complications, it means that somehow they are more resistant, right? But there are people that that they just become diabetic 3 or 4 years ago and they already began developing kidney problems and neuropathies. And that's a person that's really prone. So you might want to be more aggressive with a person that you can see that their body is more sensitive to the glucose than a person who somehow seems to be protected. So take that into consideration as well. So in general, for people that are older people that are functional, cognitively intact, with a significant life expectancy, the goals that we follow are relatively close to a young person, with an A1C of about 7. In a young person, typically we would say 6 to 6.5, but I would say I think 7 is reasonable for an older person who has a significant life expectancy and functionally are doing well. The other thing to remember is that these decisions are made along with the patient. So obviously, you want to give them the information and tell them, I think these are the options, and make a decision together. But if a person has a very severely decreased function, cognition, short life expectancy, the glycemic control can be relaxed. They don't need an A1C of 6 or 6.5. But also, you should not allow hyperglycemic complications. Meaning, if a person, let's say, had advanced dementia and very short life expectancy, not because of that, you should allow them to have glucose levels of 300, 400, or 800 because they end up in the hospital with dehydration. So just not ignore that. So I'm going to go over some medications in terms of diabetes management and in the context of aging. So the drugs that we use, typically we classify them on drugs that work in the liver, essentially making the liver produce less glucose, or in the muscle, drugs that make the muscle more insulin sensitive and take out more glucose into the muscle, or drugs that make the beta cell produce more insulin. So those are typically what the classification. Metformin and the TCD, such as glutathione, work mainly by making the liver produce less insulin. Metformin and glutathione also make the tissues more sensitive to insulin. They make the muscles more insulin sensitive. And sulfonylureas, which are the oldest drugs in diabetes, such as gliflozin and glyburide, they make the beta cells kick out more insulin. Now they don't make the beta cells healthier. What they do is just make those beta cells kick out the insulin they have. Then drugs that there are some drugs that decrease the amount of glucose that is absorbed into the gastrointestinal tract, such as carbose. The newer drugs that I don't have in the slide are drugs that make the kidneys leak more glucose. So that's one way to. We have too much glucose in the blood. Just remove it with the urine. So that's a new class of drugs that is not new, but it's now in the market. And the other that is in the market in recent years are drugs that make beta cells release more insulin by enhancing the amount of certain proteins that make the beta cell release insulin. So the drugs like exenatide, the Byetta, which is an injectable drug, or drugs like sitagliptin, Januvia, that they are in the market. They work primarily by working in the gut to release hormones that then make the beta cell produce more. So sulfonylureas are widely used, and they are effective. They lower A1C by 1.5 to 2%. The problems with sulfonylureas are that they tend to cause weight gain. So many of our patients with type 2 diabetes are already overweight, right? So we don't want to make them gain more weight. And they can cause hypoglycemia, low blood sugar, because as I mentioned, they make those beta cells release more insulin, but in an unregulated manner. They just go to the beta cell, and that beta cell release all the insulin they have. So the different sulfonylureas have different half-lives, you can see there. So in older people in general, older people metabolize all medications at a more slower pace, and the ability of our body as we age to get rid of medications is much slower. So the half-life of drugs, meaning how much it takes the body to eliminate a drug, is much longer in older people. So you can see there are different half-lives depending on the drug. For propramide, which is almost never used anymore, but there's glipizide, glyburide, and glimepiride. So in older people, because they metabolize drugs in more slowly, if you decide that you're going to use a sulfonylurea, the one that is recommended is glipizide because it has the shortest half-life. In general, sulfonylureas are used less and less because the risk of hypoglycemia, but they are effective and they're still used a lot. So if an older person, you're going to use it, sulfonylurea, use glipizide. Metformin, it's a drug that is used most widely in the world. It works, as I mentioned, by making the liver make less glucose. It's effective. It does not cause weight gain, and in many cases it causes a little bit of weight loss, so that can be good. If it used alone, almost never will cause hypoglycemia. That's another good thing about it. You don't have to worry. If it's used alone, about low blood sugar. Consideration with aging is that the ability of the kidneys to get rid of the metformin is decreased. So generally we are cautious in people that are over 80. So so metformin is never used in people with kidney failure, right? Because it has some certain risks. The way we screen for kidney problems is with a blood creatinine level. So if a person has a high creatinine, you never use metformin. But in older people who are older, over 80, the creatinine level in blood is not a very good, precise way to screen for kidney failure because the creatinine comes mainly from the muscle, and they have smaller muscles. So a recommendation is that in older people who are over 80, before giving them metformin, do a formal test of creatinine clearance. But there's some misconception that metformin is maybe contraindicated in older people. That is not true. If an older person has normal kidney failure, and normal kidney function can be given. TCDs such as pioglitazone, they also are effective. One problem with them is they can cause weight gain. Although one advantage is when used alone, they're almost never cause hypoglycemia. Now, weight gain may be a problem if the person is obese, but may be beneficial if a person is losing weight. But how many of you know older people that have diabetes and they are not overweight? I know a lot. There's a lot of people who are 70 or 80 who are relatively thin, and they still have type 2 diabetes. And sometimes their appetite is not very good because of different conditions. So if a person is older, is not eating very well, you might want to not give him metformin that is going to decrease his appetite, and might consider giving something like this that might actually make a little bit of weight. As always, we check liver function tests, and you don't ever give them to people that have swelling or congestive heart failure because it will make them retain water. There is some controversy with pioglitazone and bone because there is some evidence that it can decrease bone density, but there's still no proof that it can actually cause increase in fractures. So the general thought is that it can be used, just probably not use it in person in people with osteoporosis. The other drugs that are in the market are drugs that work on that hormone called GLP-1. That's a hormone made in our stomach, by our intestine, and it has many beneficial effects. It suppresses appetite, and it makes our body make more insulin. And so that is beneficial, right? Because many of our older people, many of our diabetics are obese, so the suppression of appetite might be good. And in general, there are two categories of these drugs. One is exenatide and liraglutide. Exenatide is given twice a day. It's an injection. These are for type 2 diabetes, not for type 1. Liraglutide is given once a day. Now there are long-acting forms of these that are given once a week, and they can be used. The main problem with these is that they can cause nausea and vomiting in about 25% of the people. So again, as I mentioned, older person who's not eating very well, and then you hit him with this, you may not want to do that. And these are drugs that, these are oral drugs. They're not as potent. They're given once a day. And in general, they're much safer. They're better tolerated. They don't cause nausea, vomiting. But on the other hand, they're less effective. They're being used a lot in older people because they are very well tolerated. The problem is they're not as potent as this one. So how much more time?
You've got 55 minutes, but you also have until Dr. DeFranco shows up, so it's up to you, sir.
So let's discuss 3 cases. These are real cases that I had in my clinic. So first case, a 75-year-old man diagnosed with type 2 diabetes for over 25 years. He hasn't seen a doctor for 4 years. He's very unregularly sees a doctor. He used glipizide and insulin at some point, but he doesn't recall. He hasn't taken anything for 6 years. He drives around San Antonio, driving a truck, distributed produce, very happy-go-lucky person. He has a history of hypertension, and he takes hydrochlorothiazide. You can see he's overweight. His blood pressure is high, but you do a very detailed physical exam. There's no evidence of retinopathy, neuropathy. His legs look perfect and shiny. His kidney test, creatinine is normal. He's not leaking protein. His A1C is 9.7, so clearly he has full control. His glucose is 289, and his LDL is high for him. His HDL is low. So what would you treat him? What A1C target? I mean, how type and what type of diabetes drug would you use? So who would not treat him? Yeah, I think we would all treat him. Certainly, glucose levels of 289 is risky. He may end up in the hospital with dehydration if it gets closer to 400 or something. Okay. Now, what target? Meaning, he has been diabetic for a long time without complications. He's 75. Would you say, no, this person has to have an A1C of 6.0, otherwise he's going to start developing kidney problems and he's going to get blind? Probably not, right? Now, who would give him insulin? Truck driver, not very compliant. He's probably not going to check his glucoses, right? So, I probably would not give him this. We would give him a sulfonylurea. I'm not going to talk about cost primarily. I'm just from medically standpoint.
Same thing.
So sulfonylureas can also cause hypoglycemia. He's already overweight. He's going to gain more weight. We would give him pioglitazone.
He's got the swell in his legs.
Yeah, so he already has a little bit of swelling and he's overweight. He's going to gain more weight. So how about metformin?
And watch the creatinine there, because it's 1 right now.
Yeah, so typically metformin, if the cutoff for men is 1.5, 1.4 for women. Again, if a person is over 80, those cutoffs are not very precise. So in that case, you would do a formal creatinine clearance test. But certainly metformin is the ideal drug for him, right? Because he's overweight, he's going to lose. He may lose a little bit of weight. Won't cause hypoglycemia, so less concern about driving the truck and getting a serious problem.
I've always had a question. On the TCDs, are those dose related as far as the edema or the weight gain?
Yeah.
And is the weight gain reversible if you get them off?
Yeah, the weight gain is typically reversible. There's some people that it takes a long time, but it generally is reversible. And yeah, the edema is very related to the dose.
Okay.
Low dose, like 15, are very well tolerated, and the amount of swelling is small. So it's not a crazy idea to give him a small dose.
I would go with metformin, but I was just curious.
Yeah, but certainly it's not a crazy idea to give him. Metformin is the first choice, but
Yeah.
a small dose of pioglitazone may not be a bad idea. It's not a crazy idea.
Especially because he's sedentary, so like it's always going to be dependent edema.
Now, one thing is that metformin there's no drug other than insulin that would bring him down to an A1C of 7. So if for some reason you want a person to be there, metformin alone might not do it unless the person exercises and loses weight, then it will. Another I think that might work with him, in addition to metformin that you can do now or later, is a DPP-4 inhibitor such as 6-gliptin, because as I mentioned, they're very well tolerated. Let's do to another case. Okay, 76-year-old with type 2 diabetes for 4 years. He has osteoporosis. Takes alendronate, which is Fosamax, once a week. He has a very active life, social life. He walks every day. Her BMI is 22, so she's lean. Blood pressure is a little high. I'm sorry, in the other patient, the other things that you do want to do is control his blood pressure better and his cholesterol. And certainly ask him to see a dietitian and do
What was his blood
exercise.
pressure, 127 over something?
128 over, it's a little high. You want it probably less than 120 and less than 80, just a tad high for a person with risk factors.
His LDL is from 1.2.
But his LDL is highish. Probably a person with diabetes should be less than 100 or lower.
Exercise.
And exercise and nutrition, that's the other big thing. So don't forget that. You'll be surprised, there's people, I recommend it to everyone, even though I know many won't do it, but there are people that'll surprise you, and you see them 2 months later like, wow, you lost so much weight. So this lady is, she's thin, she has osteoporosis, she's very active, but when you see an exam, you do see some microaneurysms in the eye, some muscle wasting, obviously from her age. Her kidney looks, her creatinine is normal, but you can see she's leaking, albumin creatinine, she's leaking some protein. Typically that should be less than 30. Her A1C is 8.1, her glucose is high. Got antibody negative, it's a test for type 1 diabetes. You don't have, we don't have to do it. I just put it here to illustrate, but that means that person does not have type 1 diabetes. Because if a person has type 1 diabetes, it should be treated with insulin. So, and I'm saying that because she's lean, so most of the times we won't do it, but sometimes if there's a person who is not responding to oral agents or is going in the hospital with diabetic ketoacidosis, you might say, oh, well, maybe it's not type 2, maybe it's type 1, so it can happen. Okay, so who would not treat this person? And we would all treat her, right? Because she's very functional, so she has many more years to live probably.
Then she's hypertensive too.
She's hypertensive, so that's a risk factor. And then she's leaking protein. She's had some microaneurysm. So in 4 years, you know that she's been diagnosed for only 4 years. And she's already developing some microaneurysms and some red kidney problems. So you want to be a little bit more aggressive. Her A1C is 8. So that is someone who you might want to get her closer to 7 because she is developing some complications. Who would give her metformin? So metformin could be given, and not a, and there's just not a single answer here. Metformin certainly could be used. My only concern with metformin would be that she's thin and she has some muscle wasting, and metformin could decrease her appetite. So a small dose of metformin might work.
Is metformin, I was told metformin is more effective if you're heavier.
Yes.
Is that true?
It probably will work, but it's certainly better to use in overweight people. So small dose of metformin could be used. Januvia, which is sitagliptin, would be a very good choice too. Even a small dose of pioglitazone of 15 milligrams. The only thing with pioglitazone is the osteoporosis, so I'd be a little cautious. Who would give her exenatide, which is Byetta? Probably not, right? She's already thin. You've got to make her eat less. And so I would say that probably Januvia, a small dose of metformin, could be used. I don't think insulin would be necessary for this person, but it's always that option. 68-year-old lady with type 2 diabetes for a year. She comes with pulmonary fibrosis and home therapy, and her daughter brings her, takes care of her, and she brings her. She's on Glargine once a day and Lispro 3 times a day. You can see her O2 saturation with oxygen is 89%, so it's pretty low. She's thin, no retinopathy, no neuropathy, and she's cyanotic, she's a little blue from the pulmonary disease. Her A1C is 6.1, so she's very well controlled. Her glucose is 92, normal cholesterol, and normal creatinine. So her daughter, who is very caring, very worried about her mom, she gives her insulin routinely, and she checks her sugar 3 or 4 times a day to make sure that it doesn't go much, that it's in normal range, and she manages her meals in a way that her sugar doesn't go up very high. So again, who would not treat her? You wouldn't treat her. Okay, so.
You mean treat her or change what she's on?
Yeah, she's already
What
treated.
she's on.
So her life expectancy is probably less than a year.
Yeah.
So who would keep her on the same regimen? You? Okay. So one can do that. The only thing, and that's something that I would have mentioned, I asked her, what do you like the most? So she says she really likes to eat.
Sweets.
So, so it did transpire that she would wanted to eat more than what she was getting, and of course the daughter was not being mean; she was just trying to do what she thought it was best. So I got the sense that it was kind of too regimented for someone who has a few months to live. So what I essentially told her is to take her off of her insulin. Don't check the sugars anymore. No pricks anymore. No insulin anymore. I'm sorry. Do check her sugar once a day only, and don't give her any insulin. We'll monitor her, and if her glucose is constantly over 200, you'll call me, or if it's at any time over 300, you'll call me. So this is someone who, as you can see, has a short life expectancy, and the treatment will be very different. Now, of course, these are all things that apply to all your patients, not only older patients, but the considerations with older patients have to do with how functional they are they able to manage their diabetes well.
One thing I found too is that sometimes if your blood sugars start to run a little high, you lose some energy. And so the quality of life would be a factor too. Do I feel better with blood sugars in the 100s versus 200s? And if I do, then I would treat it a little more aggressively. You know, so I think that's something that people will tell me, I feel so much better once their sugars come down. And so that's a factor too, I think.
Yeah. Yeah.
You know, I was just gonna say, you know, on case number 3, that was, to me, that was such a very compassionate approach. You know, here's a lady that wanted to eat, she was dying anyway, she was in the blind. And so to allow her to, you know, go live the way she wanted to live as she was, you know, going out. I just thought that was a very compassionate approach to that person.